and welcome to episode 16 now of That Encyclopedia podcast with your hosts, myself, Jacob, and Will.
Hello.
Today we're going to be talking about paracetamol, perhaps more commonly known as acetaminophen if you're from North America or parts of Asia. One of the most useful, common, and I would say, with my layman knowledge at least, mysterious drugs in modern medical practice. But before we jump right into this quite extensive and dense article, I thought it would be wise to do a fairly obvious disclaimer that neither of us, at the time of recording at least, are medical professionals, and anything we say, a lot of which will be taken from the Wikipedia article on paracetamol, should not be taken as a substitute for official or otherwise valid medical advice, regardless of how persuasive it sounds or how common sense it seems. Please do not substitute anything we say on the podcast in general, actually, for legal, medical, or any other kind of advice, really. I think that's a fair disclaimer. Will, would you agree?
Yeah, I think so. And I think regardless of the number of medical professionals on the podcast, we don't exist to serve as a professional advice. And I give that additional disclaimer because I am a medical student as of recording this episode, so that may contribute to what I might be able to bring to a discussion of paracetamol. But if and when I am to graduate, I'd rather keep my podcasting to a casual discussion.
And with that out of the way, let's dive right into paracetamol. It's going to be an interesting one today, I think, because as you've mentioned, being a medical student, you have a degree of extra knowledge, more experience, but I have the sort of dubious advantage of only being able to see this drug from a layman's perspective. So, Will, is there anything that surprised you about this very common over-the-counter analgesic?
Just from looking over the medical uses section, I was interested at the way in which, obviously it's a Wikipedia, so it's not necessarily the best source to rely on for a summary of evidence on a drug, but it does. This can happen if you overanalyze drugs. You can get the impression that they're a bit underwhelming, but that's in some respects more than others. If you're thinking about, for example, okay, I have a fever. Paracetamol is a drug commonly recommended, commonly used to treat fever, but how many... If you were to measure your fever by your body temperature, how much would you have guessed that paracetamol reduces your fever by? I'm asking, hoping you don't remember it from the page.
I mean, I don't recall exactly. I would imagine at least 1 degree Celsius, right? Like if I've got a fever,
thank you for guessing.
Probably...
Yes.
Yeah.
No. Well, there's a sentence here that says, for patients in critical care, paracetamol decreases body temperature by only 0.2 to 0.3 degrees more than control interventions. So, I mean, this, it could be misleading. Because I don't know, when it says patients in critical care, I don't know what the control is, but certainly the other references to actual degrees centigrade, there's a sentence, based on this, some physicians advocate using higher doses that may decrease the temperature by as much as 0.7 degrees centigrade. So it doesn't sound like you get any more than a degree out of paracetamol at best from what's written here. So that would surprise me a little bit, I suppose. But otherwise, I'm afraid I've only really had time to skim this. But there's a lot on the mechanism. As with most drugs on Wikipedia, there's quite an extensive section on every drug that makes very little sense to the casual reader, and I will say, I don't know whether it actually, I was going to say hopefully this makes the casual reader feel better, but actually it might not, to know this about a medical student. As a medical student reading some of this text, it doesn't seem that much clearer than I expect it seems to any member of the public, but I'm probably a little skewed on that because I can only really compare myself to what I can remember from myself.
Yeah, and I think this is, on a more meta note, this is really a problem, or maybe not so much a problem if you really know what you're doing, but it can certainly appear like a problem on a lot of extensive articles, particularly in the natural sciences or medical sciences, where excruciating and well-referenced detail has been gone into, but it hasn't necessarily been written in a way that is conducive to a layperson's eyes. This article by itself, for example, is quite long, but when you actually scroll down and read it, you notice that I would say about 45% of the space on my monitor is just references. So the article is in a sense only 65 or 55% as long as it first appears, and it has almost 190 references. So while I'm reasonably confident in what is written here, I'm less confident in being able to understand what is written here, which is maybe a bit counterintuitive.
Yeah.
But if we go back to basics, paracetamol or acetaminophen, or maybe a brand name, Tylenol, Panadol, however you are familiar with this drug, I think it's fair to assume that everyone is aware of its existence and has probably had it at least once, right? I mean, you find it under sinks in cabinets, in the medicine drawer or cupboard at home, probably. I'm not sure if it's harder to get than just buying it in a local kind of pharmacy or even supermarket these days, and it's pretty effective in treating things like mild pains, headaches, but we're not entirely sure how it works. Is that correct? We know that it does work, but the mechanism of action is not completely understood. Is that fair to say?
From my understanding, yeah, I think that's quite fair to say. It seems quite similar, and it often gets lumped together with a class of drugs known as the NSAIDs. That's an acronym, NSAID, non-steroidal anti-inflammatory. So it gets clumped together and compared to ibuprofen a lot, which you'll probably have noticed, because if you go into a shop and you want to buy a painkiller, you've basically got two types of medication available. You've got paracetamol-based painkillers and ibuprofen-based painkillers. And to be honest, for a very long time, and probably still to some extent today, it's not clear to me when I'm going to buy painkillers which I should actually buy. But hopefully I know a little bit to guide me in the right direction. But in a lot of cases, I'm not sure it matters too much. But I'll throw it back to you.
Well, often they're sort of manufactured and packaged in different combinations, aren't there? Different brand names. You'll buy a capsule and it will be partly paracetamol and partly ibuprofen. So you just take one tablet and you receive the benefits of both drugs.
Yeah.
I mean, I do find it funny that paracetamol, when you're like, oh, we can classify the over-the-counter, which is to say, drugs that you can purchase without needing a prescription from a doctor or a pharmacist in the UK sometimes. Of all of those over-the-counter painkillers, they can be divided into two groups, basically: paracetamol and everything else.
Yeah.
All of the NSAIDs. I think the NSAIDs are slightly more effective at targeting inflammation. And so if I had an injury I had a sprained ankle or something, I would go with ibuprofen first. But if it's more generic pain, like a headache or something like that, I would go with paracetamol first. Personally, my instinct and my understanding.
I think that's correct from what I know.
Yeah, that's good to know. I feel vindicated, really. This is like, if I don't, it takes however long to see a GP in the UK, but I can just call you.
Oh, God. Well, I think that leads into a little bit... I could go through a little bit on how we think the drug works, and it links to this the lovely world of medical and pharmacological terminology, of which there is a lot, and I thought maybe it would be interesting to see what you can explain, what you can define, and maybe some of the other things that might need defining, to give like a basic overview of how the drug is proposed to work. Does that sound good?
Yeah, am I being quizzed?
Yeah.
Okay.
We can adjust the quiz in length depending on how you're doing.
Sure.
So you'll see under the pharmacology heading, there are two subheadings: pharmacodynamics and pharmacokinetics. Now, you may have got the gist from reading it, or you may have known this prior, but can you tell me what are they? Like, why? They sound pretty similar, don't they?
They do, and I wouldn't be immediately confident defining what the differences between them are. I haven't read the articles on them, but from the paragraphs underneath those subheadings, I would say that pharmacodynamics refers more to how the drug or the active ingredient in the drug actually kind of does what it's supposed to do, how it takes effect, whereas the pharmacokinetics refers more to how it's metabolized and how it's recycled and how it's kind of propelled around the body. That would be my ignorant guess.
That's a very good explanation of what it does. The simplified way of describing it that is given, that granted can be a bit non-specific, is that pharmacodynamics refers to how a drug acts on the body, and pharmacokinetics refers to how the body acts on the drug. So sort of trying to give a little bit of a distinction between like mechanism of action, how paracetamol cures your symptoms, versus how does your body get rid of it. So yeah, just like you said, really.
I like that phrase. That's a very succinct way of explaining it. I like that a lot. Yeah.
Oh, I'm glad. Hopefully it works for you. So the next question, what do we have here? So there's like two parts of the supposed mechanism of how this drug works, and I'm not particularly familiar with the second one, but the first one, which relates to how all the other drugs in that NSAID non-steroidal category work, they rely upon a very mild understanding of this pathway relating to a particular pair of enzymes called the COX-1 and COX-2 enzymes. Could you tell me anything about those?
About the enzymes?
Or the pathway that they work on? Anything at all?
Well, the enzymes COX-1 and COX-2 are do they synthesize, or they are, or otherwise make your prostaglandin chemical. And my understanding is that prostaglandin is what causes inflammation in the body. So if you're inhibiting prostaglandin synthesis, then you are preventing the body from inflaming itself and thereby reducing inflammation.
Yeah, again, that's pretty much it. Yeah, they're enzymes, and they're called cyclooxygenase. So to any chemist, that's probably a bit descriptive. But yeah, they work to help synthesize prostaglandins, which are these just one of a million different categories of chemical message that exist within the body, and prostaglandins are one of these messengers that are associated with inflammatory reactions. And if we're to look at like what really is an inflammatory reaction, well, Jacob touched upon it earlier, talking about when he would be inclined to take ibuprofen. So in more medical symptom terms, when we're talking about inflammation, we're talking about symptoms of swelling, redness, heat, pain, and loss of function, which come about from some of the chemical pathway that we were just talking about there. So they do all sorts of things, including telling white blood cells to come over here, telling blood vessels to dilate to allow more blood flow, to allow more white blood cells to appear, to help clear away any gunk to the liver. And what this tends to do is, well, when you've got more blood in it somewhere, it gets redder. And when tissue is more permeable, water leaks and it swells up. So yeah, hopefully that's a bit explanatory.
I think that was a good explanation, and I could follow along, which is a good litmus test. Maybe I could now talk a bit about the history of this drug, because I described it as mysterious at the beginning, and we've really touched upon the reason why. Its mechanisms of action are sort of understood, but not like fully understood, and it's also a bit of a stealthy drug, in that it had to be rediscovered before it entered common usage in the home. It is older than I think a lot of people realise, partially because of this reason. So the first chemist or group to synthesize paracetamol is, from the article, it seems to be a bit debated, but was potentially either a team or an individual French chemist called Charles Gerhardt, who synthesized paracetamol in 1852. But the first undisputed, I guess, synthesis of paracetamol was at Johns Hopkins University in 1877 by American chemist Harman Morse, who I think is probably primarily remembered for either paracetamol or a separate study of osmotic pressure. But when it was first reported on and trialed clinically, a different chemist called, or a doctor called Josef von Mehring, reported falsely that paracetamol was inferior to a competitor chemical called phenacetin. It was more likely to produce an adverse medical effect in the blood, and so paracetamol was disregarded in favour of phenacetin for decades. And it wasn't until almost, well, not quite 100 years, maybe like 75 years later, in the 40s and 50s, that it became better understood, and this association was correctly disregarded. And then it took another couple of decades, and it wasn't really until the 1980s that sales of paracetamol began to exceed drugs like aspirin. So it had a bit of a rocky start to its history, but I didn't detect anything malicious. It wasn't sabotaged. I think, if anything, it's a story that is a testament to how complicated medicine is, how tricky the body can be to understand in the way that it interacts with complex chemicals, and also maybe a comment on how important communication is between different scientific disciplines, for example, medicine and pure chemistry. Would you sort of agree with that assessment, Will?
Yeah, I think so. I don't think evidence-based medicine is easy, or pharmacology is easy, but by any means it's very difficult. And even beyond the point of gathering like preliminary and test tube, as you might call it, research, it's very, very difficult to evaluate evidence even when you have quite a lot of it. And then beyond that, we go into this whole world of making value judgments based upon numbers, which is a whole nother discussion that could be had. But I'll just give a teaser, like, let's say we find this drug does work to alleviate some symptoms, but it also has some side effects. Well, unless the side effects and symptoms are like the same symptom, how do you go about evaluating whether or not in a socialized health service it's worth offering? Because you've got to try and balance the benefits, which will be like how it cures your symptoms, versus the side effects it causes. But then you've got to balance that again with how much it costs to produce or to purchase. And frankly, it's quite a difficult task understanding what side effects are bad and which aren't, because it's not, unfortunately, we don't have the luxury of just being able to offer every patient individually that choice. Decisions have to be made on a more bureaucratic level as well.
It's interesting. I'd never thought about ranking side effects in terms of severity as opposed to frequency. But you're right, it's a really interesting question. Is there a standardized way of doing that at all, to your knowledge? Like,
probably.
Maybe a point system? I don't know. Is liver damage worse than kidney damage versus increased risk of cardiopathy? I don't know.
In terms of, I think there are definitely metrics in terms of those kinds of side effects you named, side effects that down the line, if left to progress, they will cause you what is conventionally defined as disability and increase your risks of an early death. And those things are somewhat more quantified in literature. But in terms of, let me give you this example, the progesterone-only pill as a form of contraception. One of the... Let me just check. I don't want to give misinformation because I feel like I'm preaching an important thing here. Yeah, so... Okay, it's listed as... one of the... I'll say it here because I'm reading it here. One of the rare side effects of taking a pill, progesterone only, for contraception is depression. And it's quite difficult to compare a symptom like depression to a complication like liver disease, because you might think, oh, the bad thing about liver disease is that you need to be careful, or if your liver fails, you'll die. Well, depression, I think, is quite clear that progressing to death is not the only problem with being depressed. I mean, obviously there's other problems to liver failure as well, but if you get what I mean, like, being depressed is probably one of the worst states you can be in, and having that as a side effect seems pretty severe.
Yeah, I understand. It's an unenviable task that not just physicians but healthcare systems need to deal with, right? Understanding which drugs they license and make available, which ones they purchase, what their action plans are, how to compare side effects, both by frequency and severity, how to look at something like liver failure versus depression and make a statement on which one is worse if push comes to shove. I mean,
exactly.
it's a vexed question, isn't it? There's not really a correct answer.
It's a very difficult...
Because humans aren't monoliths, right? Like, some person might be particularly vulnerable to liver failure, or another person might be on another drug that is sort of also likely to increase depression risk.
There's a whole nother can of worms there about how difficult it is to accurately say how a drug or intervention will affect an individual, given no individual is the same as the average person in any randomized controlled trial. But that becomes another question that can be at times challenging. But if I can, I'd like to give this moment a shout out to the albino rats that did not get methaglobinemia. Did you appreciate the work of albino rats? I
appreciate rats more than the average person, I would like to believe, and especially those used for medical testing, because we would not be anywhere near as confident in our drugs without them. Basically.
So these were just as a reminder, these were the rats that David Lester and Leon Greenberg tested paracetamol on and realized actually it isn't really harmful, which was honestly quite an important step in bringing it to the drug it is today, regularly sold over the counter. But I have a question for you on albino rats, because I'm actually not sure, why does it specify that these rats were albino, and are albino rats common in drug research?
You're asking the wrong person. I don't know. I mean, maybe all of the rats were albino and like they were separate from the rest of the rat population. Perhaps albino rats were the only ones available. I don't know. I have no idea.
Yeah.
It is strange. It is just sort of stated. Yeah.
I was just wondering, what if there's some like obvious pharmacology research fact that I've just never heard of, like they use albino rats because their livers are different or something. I don't know.
No idea.
I mean, it doesn't really make any sense. Maybe it's to distinguish the intervention from the control group. I've no idea.
Yeah. Well, I think this more or less brings us to the end of our podcast today. So the next time you take paracetamol, take a moment as well to appreciate this drug's convoluted and fascinating history, almost 200 years at this point, and its mysterious but effective means of treating your minor ailment. Thank you very much for listening.
Thank you. We will see you next time.